So there are two different processes here. One is for entering something like blood pressure, height, weight. Anybody could do that. Absolutely anybody could do that. In fact, there are many systems that are part of larger organizations where they're not entering that information at all. They're actually getting that information from another system, especially demographic information. It's being loaded from a practice managed system automatically. But when it comes to CPOE, we're very specific about who enters that information. So the information either has to be entered by a licensed healthcare professional, and it has to be done prior to any action being taken part on the order, or it has to be entered by a certified medical assistant. So you can't have a layperson who enters that and then somebody goes through and just clicks a button. You have to have the actual licensed healthcare professional or a CMA actually enter the information.
So the auditors would find out that the layperson entered it all, and then it'll say select all yes or select all no, and he clicks on that and clicks on that, and then they know that he didn't actually enter it?
So I get this question a lot, and if what you're asking me is can somebody sign in as the physician and enter information on the part of the physician, we would, of course, have no idea about that. I would encourage no one to do such a thing, though.
What if they signed it under themselves? I'm just saying then the physician later on clicks on it. Is he, can he
most
select
systems
that as one
don't
of
work
his?
that way, so that when you go to actually do CPOE, if I, as a layperson, were to sign into the system, I couldn't actually do that type of ordering. This is sort of what Epic does.
Our system, Epic, does allow that.
Okay. In that case, I think the actual, again, order entry has to be done by a licensed healthcare professional or a CMA.
Well, our Epic system has the person's name, and it just says medical assistant, even though they're not certified or anything like that. It just has that as a name. And then the physician can say, I'll select, and he can select all the medications and just sign off like he did it.
So it is supposed to be order entry, again, by a licensed healthcare professional or a credentialed MA. It's not a penalty, but you wouldn't be able to count those people as part of meaningful use for CPOE. So if I as a layperson go through and I complete a medication order, we don't have any jurisdiction over whether that is allowed, although there may be some local or state regulations that cover that. But as far as meaningful use is concerned, it means that you couldn't count that order within the numerator of that particular objective. So it is possible that because of how that is calculated, you might not meet that particular threshold for that objective. But it's not a penalty that we apply for it. It's just you couldn't count those orders toward the actual meaningful use objective. And the purpose of this really is to make sure that when that information goes into a system, and it is done obviously prior to any action being taken on the order. Right now it's medication orders, but soon it'll be medication lab and radiology orders. That somebody who has some clinical expertise or authority is able to see any of the clinical decision support alerts that might pop up and say, you may not want to prescribe this medication because of a counterindication. And then they can take action on that for patient safety. Whereas I, as a layperson, might see a clinical decision alert and have no idea what that means and ignore it completely. So that's really the whole idea behind having a licensed healthcare professional or a CMA to look at that. Yeah, and that's an excellent question for confirmation. So there are a lot of practices that work exactly the same way where the physician, I'm not encouraging this as workflow, but I know for a fact that it happens. The physician is not actually using the electronic health record. They are still writing things down in a paper chart, and it is administrative staff that is actually entering most of that information. That is acceptable. I hope that as electronic health records become more of our landscape, that type of dual paper and electronic system will disappear. But a lot of practices work exactly that way, where there are front office staff who are basically entering a lot of the other information, and then it is a CMA or a licensed healthcare professional that's actually doing the medication order entry. So there are tons of EHRs out there, but we specifically require certification for use of this program, and the purpose of certification is that a vendor then has to bring their product and they have to pass a series of tests to demonstrate that their EHR can achieve all of the objectives that are required for this program. So they are able to show that they can do the calculation of a minimum number of clinical quality measures. They can show that they can do e-prescribing and CPOE and recording information in a structured format that is required for this program. So really, the certification designation is a guarantee for this program that the EHR that you've chosen is actually capable of allowing you to meet meaningful use. So there's not a requirement as part of certification that your certified EHR has to identify you as a credentialed MA. There's actually not a requirement within certification that you have to be identified as anything. However, for purposes of entry, for purposes of workflow, the EP, the practice, has to make sure that that's who is entering that information. We realize that not every EHR may have that information, but certainly a large number of them do, and I can anticipate that an auditor would ask for that log.
So as a follow-up, would whoever audits have to look back and check that the staff is credentialed or licensed?
I can't tell you what the requirements for an auditor are, but I can certainly tell you that it's a potential that an auditor may ask that information.
Mm-hmm.
There are a variety of ways that people, I think, are working with their patient base to try and get them to use an EHR or use a portal or access their information. Some practices are literally putting computers into their front rooms and having patients access that, walking them through that process. That's purposely why the bar for this was set very low at 5%. I think that you're going to see more and more strategies sort of emerging for exactly that, for folks that have a population that either doesn't have access to computers. We have a number of Medicaid providers who are working in particularly challenged audiences that don't necessarily have access to it. A lot of folks who are
being a
homeless.
rural county, it makes it even worse.
Well, now there is an exclusion for folks who practice in an area that has low broadband availability, because that is certainly a very high threshold for people to overcome. So. Well, we don't actually have any additional regulatory authority beyond what we have with incentive payments and payment adjustments specific to this program for CPOE. You're absolutely right. It is possible for anyone to game the system here. Why an auditor might look at credentialing and would look at those audit logs to see whether or not that is likely to have happened. The authority here of the cloud is either if an auditor goes through and discovers that people were erroneously counted within a numerator and you did not actually meet meaningful use, you would forfeit an incentive payment and then potentially be applied the payment adjustments. So certainly, if an auditor comes by afterwards and discovers that your attestation was not correct, then it would be a forfeit of payment or a recoup of payment, and potentially things that are egregious fraud do get sent for additional prosecution. So I can't tell you the percentage of physician offices. I can tell you that there are 527,200 eligible professionals who can participate in this program. And currently we have about 315,000 who are actually using electronic health records. Out of that, I want to say there's 230,000 that have actually become meaningful users. In case you're not sure, on the Medicaid side, you can actually participate in your first year by just getting an EHR, just implementing it into your practice and not becoming a meaningful user yet. So they're starting to catch up, but not everybody is a meaningful user yet.
Yes, my response was that someone who is in a medical assisting program, who is a student, does not yet have a medical assisting credential and therefore could not possibly be in the category of credentialed medical assistant. The answer to that is that it is not restricted to any one particular credential. Last year I stated that Congress did not have the authority to determine what credentials are acceptable or are not acceptable. That's really something that is a state law police power issue. And therefore, CMS does not have the authority to make those determinations. Currently, the definition is that a credentialed medical assistant is someone who has a credential by a third party. As I mentioned earlier, having someone pass an in-house test and be given an in-house credential would not qualify. But there is no limitation of those credentials. In fact, another source of confusion is that only the 4 medical assisting credentials that are accredited by the National Commission for Certifying Agencies are acceptable. That is not the case. There is no limitation in the rule. It merely says the credential must be from a third party. I just have 2 final comments. First of all, I think that providers, in fact, all Americans should abide by the law. You know that the tax system is a self-enforced system, as the IRS will tell it. But just because only 1 out of 200 people are audited doesn't mean that everyone else can take a chance and just flout the tax laws. So I think when we're talking about this, I would assert that something doesn't have to be rigorously enforced in order to be obeyed. I think there is a duty under both federal and state law for providers and for all medical assistants to abide by the law. Secondly, getting back to Maggie's question, remember that there are certain thresholds, a certain number that have to be met. So it is possible if the provider fails on that one point, in particular this CPOE as to who is entering the orders, that could totally do away with all of the reimbursement. I understand there's no partial reimbursement. So is that correct? If there is a failure to meet one point, that would eliminate the reimbursement?
Yeah, that's correct. If there is not meeting all of the objectives for meaningful use for a program year, then that payment would be forfeit. And as we're entering now, 2013, for those who have already started participating in 11 and 12, 2013 is really a deciding year for payment adjustments as well. And as we move forward, of course, every year is going to be a deciding year for payment adjustments. So potentially, if an audit comes through and you forfeit a payment, you may not only be forfeiting the payment, but you would also be subject retroactively to payment adjustments as well. So.